Thank you so much for coming back. So we're going to dive into the nitty-gritty things. So we do a lot of these sort of conference talks. Whenever we get, have a legal session, they tend to be extremely popular because there's all these subtle details. If you want to actually do telehealth, if you don't have the legal aspect clear, then you just can't do it. So we're really excited to have 3 other industry experts. We're super excited to have them in our conference. And so first up, we have Charles. Again, so he's going to dive into some of the specific issues around reimbursement. What's interesting about him is he loves football and barbecue every weekend. If he couldn't do it, he's very, very sad. And he also has a magic superpower. He can count and guess the number of jelly beans very accurately. Next up, we have Lara. So Laura's going to dive into a lot of the AI, machine learning, chatbot. There's tons of legal issues. Again, she's going to dive into some of those considerations. And again, we seem to have a theme, a lot of professional, semi-professional athletes. So she's actually a triathlete. She's going to be doing a half Ironman in the next April. And then lastly, we have Joe. And Joe's going to dive into something specifically about the drug prescription, Ryan-Haight Act, again, some of the really subtle details. Again, if you don't get these right, your telehealth could get into not only severe legal issue, just really trip you up in there. So what's interesting about him is he just completed his duty as a father of the bride, and he just came back from Alaska. Again, so thank you so much so the format is that each of them will come out to present, dive into a little bit, and then the other 2 panelists will make some comments on this stuff. Then the next person will dive into their area. After they all finish, then we're going to open up the questions to the audience. Okay. So, Charles? Okay.
Thank you, Milton. Attorneys are notorious for being long-winded, but I have 5 minutes to talk to you about reimbursement and telehealth, so it won't be. We all know that adoption on a national level is being hindered by coverage and reimbursement. It's a big issue that everybody's been handling. I'm going to talk about Medicare, Medicaid, commercial payers, self-insured, kind of run through some of the things that I'm seeing. So the first is with Medicare coverage. As everyone knows, the coverage for Medicare services right now is hindered by the statutory provision within the Social Security Act, which otherwise limits coverage for those telehealth services that are face-to-face live interactions, and it limits it by locality, modality, provider type, and the like. And the process for getting approval of those Medicare services under the PFS has to go through the annual rulemaking process on a case-by-case approval based upon clinical benefits. At present, we have only less than 1% of the HCPCS and CPT codes that are covered. So these are the reasons why Medicare is being hindered. But there is a movement, or there's been a number of legislative bills that are out there to try to change this. It hasn't had much carry forward, but the Preventative Health Services Act is something important to point out. The way that any legislation would be evaluated is based upon the financial impact. This bill was introduced to allow the CBO to review expansion of telehealth services and coverage and remove those restrictions by looking at a longer period of time for the benefits of the preventative health services to be able to consider that and take that into account, because right now it's limited to 10 years. It's been sitting in budget committees May and November of 2017 for the House and Senate, respectively. What really happened recently, this July of 2018, the CMS proposed their bill for the 2019 PFS and quality payment programs. The language that comes from there is how they're defining, and in quotes, Medicare telehealth services, what was specifically under that statutory provision in the Social Security Act. And it says, we have come to believe that that section does not apply to all kinds of physician services whereby a medical professional interacts with a patient via remote communication technology. Some consider this a workaround, but it's the legalese. The value of, right now this administration is saying we want to start to reimburse for this technology more. How can we do it? And so this proposed rule is a stepping forward in that, and it demonstrates the intent of the administration and CMS to expand coverage. So here's just a breakdown of what that coverage is and the new billing codes that they're proposing that fall under or outside of that definition of Medicare telehealth services. The expectation is that will continue to expand. The final rule is anticipated in early November. So they asked for a lot of comments, and we'll see what they get back and what they do. So but this isn't the first step. We point out that there are a number of waivers in telehealth programs. So here's just the areas where CMS and Congress has acted, has expanded coverage in those spaces. Again, I have 5 minutes, so I can't necessarily go through everything. The state parity laws and the Medicaid programs, there's just a breakdown from our friends at CTEL about what the coverage is on a state-by-state basis, the modalities that are covered for the Medicaid programs, and the fees for originating site, I think, is important. What I wanted to highlight here is what we're seeing, or what I'm dealing with a lot, is my clients are really getting into school-based program, mental health services, and coverage of telehealth services. State Medicaid programs are really interested in paying for that and providing that service. So state parity laws, again, the commercial health insurers are subject to, in a number of states, to mandates that they cover telehealth services. They're not true parity laws in the sense the financial piece. So there's coverage, but the reimbursement's not mandated to be the same as if it wasn't in person. But generally what we are seeing is that commercial insurers have been covering this for years, right? But they're generally not covering it under a fee-for-service schedules, and it's not otherwise uniform across the payers. Some market reflections, as I have 30 seconds, and we'll go through it, but market reflections I think are really important and a number of the speakers have already addressed this, and I want to highlight it, is the partnering between the private payers and telehealth providers is critical. That's where we're seeing a number of our work as attorneys, working with negotiating the contracts, but also working on the payer structures, these value-based payment, not a fee-for-service. We need to stop thinking about the fee-for-service structure. We need to think about how we can add value, not just decreasing costs, but also and implement and propose additional services that telehealth and those platforms and the technology can provide. Insurers don't buy that you want to save them money, but they do buy that you want to help work with them and partner with them, and you bring more to the table than just that cost savings. The greatest movement that we've seen is in the self-insured plans. They have the ability to be flexible. They have the ability to negotiate really creative and sophisticated reimbursement structures. They change in every single deal, but we're in a position to work with them and have worked with a number of clients to work with the TPAs and the self-insured plans, whoever their representatives are. But it's really important that you understand the utilization and quality metrics, be able to provide outcome data to them. It really takes an ability to negotiate with them to receive that data, provide those outcomes to demonstrate those quality metrics and the cost savings over time. Without that data and without negotiating that information, you're not going to be able to do it. And then hospitals and health systems, just my last point, they're adopting this without getting paid because it's saving them money, and it's also patient admission lower reductions and provider collaboration. So even the reimbursement doesn't exist, telehealth services and technology are being adopted. So thank you, that's well over my 5 minutes, sorry.
I don't think I have much to add there, so I saved you some time. Do you have anything to add?
Only one thought. The Congressional Budget Office routinely marks up all the bills that are presented to it and indicates to Congress that the cost of the service will augment and not decrease or keep budget neutral the cost of health care in the United States. CTEL, which Charles referenced in one of his slides, is trying to obtain and organize all the world literature on the subject of the cost effectiveness of telemedicine in hopes that it might be able to influence CBO to be less judgmental or less harsh in its judgments about telemedicine statutes and or rather proposals in the future. So those of you that may have such data, I would heartily recommend and indeed ask that you try to provide it to CTEL, which can use it to good advantage in its efforts to try to influence CBO in a positive direction. Thank you.
All right. 5 minutes goes fast. So I don't think I need to tell this audience that we have technology moving at a rapid pace. Innovation is unbelievable. I started doing this work about 10 years ago, and I remember the first telehealth client that I had, we were literally looking at whether or not we could actually create an appropriate patient relationship using the internet. And here we are today talking about all of these amazing new technologies. That said, the regulators always have a tendency to trail behind the innovators. And so, despite all of the work that's been done by FDA to provide guidance in terms of how they are going to regulate all of these different innovations, in which, I've listed several that I end up looking at on a regular basis, there's still a lot of questions. There are open questions about how FDA may be looking at a new innovation and how they're going to regulate it. So, to a certain extent, there are more questions than answers. And when we start talking about these new technologies and providing overall care to patients, it starts getting even more interesting, because you're not talking about one particular platform or one app or one device anymore. You've got interoperability, you've got smartphones that can be turned into medical devices that connect up to a platform that's going to analyze the data for something else entirely, and then the physician's going to look at it and try to make a determination. So in terms of those of you that are really providing the patient care using all of these different tools, I would encourage you, number one, understand what you're using. How does it work? How are you collecting that data from that device? What are you doing to it? Are you analyzing it further? How is it being presented to the end user, whether that be your patient or the physician? What is it doing? What kind of information is being provided? What level of analysis is being done? So we'll get more into that, but we've got a very complex environment. So earlier today, we started talking about just the overall wellness component and the different technologies that are available there and patient engagement, right? So this isn't necessarily something that would be considered to be a high-risk area by FDA. It may be just regulated as a general wellness product. That's going to be a little bit different than being regulated as software for a medical device, which is actually being regulated as a device medical use. So, here we are again, more complex. We've got apps, we've got artificial intelligence, chatbots, data analytics. How does all of this play out? And the message I'm here to deliver to you today is there is no one-size-fits-all here. So, it could be a very simple chatbot that's asking some very basic questions. There's really no analytics going on behind it, and it may not be asking anything that's even medically relevant. It may be just kind of rote intake. But then you get more sophisticated. You start asking more questions. There's analytics in the background. Maybe there's some statistics guiding which question comes next. Those things get more complicated. So understand the functionality, understand what you're doing. So I think most folks may be familiar with clinical decision support, which, according to the 21st Century Cures Act, is not regulated as a medical device. 2017, FDA came out with guidance in this area. And even after all the guidance, it's still not 100% clear how some of these technologies are going to fall into these current regulatory buckets. So it's clear if you're just kind of collecting data that's otherwise available in the literature, you're pulling it out, you're pulling it up for the physician, they're looking at it, then they can otherwise make an independent determination. That's CDS. Once you start getting further away from that, you start getting more sophisticated, that may not be CDS anymore. But it's not entirely clear where that line is. There's so much data that's being collected and analyzed. So, again, that's an area where I think we could use more guidance. They have not issued the final guidance yet. This is one of those things that personally I will be watching for in 2019 in terms of how a lot of these innovations are going to be regulated. Medical device data systems, that's pretty kind of basic software. It's coming in and it's being presented. It's not being manipulated. There's nothing else going on with it. those are subject to basic controls. Mobile medical apps, there are a bunch of apps out there. Not all of them are regulated as medical apps. But once you start talking about a platform that's being transformed into something that acts as a medical device, you're controlling other medical devices, you're doing patient-specific analytics that start getting towards diagnosis and treatment, those things will be regulated as medical apps. So the good news is we have an FDA commissioner that seems to be very welcoming of digital health and digital technology, very excited about the promise of artificial intelligence. We've got the pilots programs going on. We're starting to see products being approved that are actually incorporating AI, and some of them have been really interesting. So we've got the DX Doctor that was analyzing images from a retinal camera. What I found particularly interesting about this product is it's making a determination on its own, and it's still being classified as a Class 2 device. It went through the de novo process rather than the higher standard in Class 3. Apple had a recent success. I'm sure I don't need to tell you guys that happened. But again, very interesting development. So, the watch that somebody's wearing that may be connecting up to your platform that right now is not a device may very well be very soon considered to be a medical device. So what does that mean in terms of the connection to your platform, how that data is being used? So that's what's going on the FDA side. Then we have the state regulation, and I just wanted to mention this as well because it's kind of the counterbalance to this. So on the one hand, we're very, very excited about the technology. Everything is, a smart questionnaire. It's really helping doctors to do what they do well, and it's cutting down on the amount of time they need to practice. It increases the number of patients they can see using the telehealth platform. This is all great stuff. We're very excited about it. The issue is, we still have patient encounter expectations from the state medical boards. And I've had some very interesting conversations in some states where I've asked, look, this isn't a questionnaire in the sense of what you saw years ago with the pill mills. Somebody went on the internet, said yes to a couple of questions, and got the pill that they wanted. Very, very biased against pill mills. I asked, look, this is actually clinically based questionnaire. It's a smart questionnaire. It's not just to click a couple of boxes type of thing, which was the issue. I've had several regulators tell me they don't care how smart my questionnaire is. It's still a questionnaire, and that's not something that you can base a patient relationship on. So there are some ongoing issues here that we're having to work through at the state level in connection with adoption of these technologies. We're very hopeful that through education that we will make a lot of progress, so I would encourage you to engage your regulators, help educate them. It's something that we are trying hard to do, and I feel that we are making some progress. So the takeaways here are, one, understand your technology and understand the current regulatory environment. Two, track the new developments, because 2019, I think we're going to see a lot of movement in terms of clarifications to the existing buckets that we're looking at on a regular basis, but also FDA is going to be learning a lot more about these technologies and will likely be issuing additional guidance, and also look at what's being approved. Things are moving pretty rapidly, particularly with the pre-cert program, and looking at what's been approved and how it's been classified will tell you a lot about how FDA might approach your new and innovative product. And finally, as I said, engage the regulators. Right now they seem to be very interested, particularly FDA, in what you're doing and how they can best enable you to develop your technology while still ensuring that it's safe for use for the public. And that is all.
I think we're short on time. Go ahead. No, we're really short on time.
Good afternoon, everyone. I take the position that with respect to the legal and regulatory issues most in need of reform in the whole world of telemedicine, nothing exceeds the Ryan-Haight Act. The opioid problem in the United States is of staggering proportions. The United States is home to 5% of the world's population. We consume 80% of the world's opioids. In 2016, about 63,000 Americans died of drug overdoses. That's 10,000 more than died in the entire Vietnam War conflict. This problem is out of control, and telemedicine provides an opportunity to improve upon it. And we have an obstacle in the way in the form of a statute enacted with the best of intentions that has unfortunately prevented the delivery of care to those most in need of it. That is particularly true in rural areas where you can't find doctors of any variety, never mind addiction specialists. It is estimated that something like 90 to 99% of the counties in rural states such as West Virginia, Kentucky, New Hampshire are without any form of mental health care, much less any sort of addiction care. Just by show of hands, among the physicians in the audience, do we have any addictionologists, addiction specialists? Okay, well, I'm not one either, and I don't pretend to be. My training was in internal medicine, and it was a long time ago. Nevertheless, the data are impressive with respect to medication-assisted treatment, or MAT, M-A-T for short. It involves a combination of medications, some of which didn't exist back when I was writing for medications, and psychotherapy of various kinds. It's been demonstrated very nicely that when MAT is employed, that the mortality rate decreases by as much as 50% among the population treated. That's an extraordinary percentage. A great deal of that service could be provided virtually if we permitted it legally, but we don't. Why? Under the Ryan-Haight Act, it is unlawful to write for controlled substances without having had at least one in-person evaluation of the patient. And I ask you to think about the logic of this from a clinical point of view. In telemedicine, why cannot one take a history every bit as good, elaborate, detailed, and careful as one can take in person? I don't think there's any reason why you can't do that. What does that leave us with? It leaves us with physical examination. It has 4 parts classically: inspection, palpation, percussion, and auscultation, right? Okay. What can we do with telemedicine? With video conferencing, we can do inspection. And with a few gadgets, we can do auscultation. What are we left with? We cannot do percussion and we cannot do palpation with telemedicine. Why? Because we cannot put our hands on the patient. Okay, name me an addiction-related problem where palpation and percussion are crucial to the diagnosis. Now, admittedly, I am not an addiction specialist. I may very well be wrong, but at least I can't think of a single one. In addition to the benefits for the management of the addiction problem, we also have better, with those who are trained to do this, we have better detection, earlier detection of such serious problems as viral hepatitis and HIV and AIDS. And yet, we have this roadblock in the way in the form of a statute that could be amended to make all this possible. If we could move forward, I didn't know we were going to have slides until 9 o'clock this morning, so poor Ann had to try to create slides from my handwriting, which is unconstitutional under the 8th Amendment, which bans cruel and unusual punishment. Under the Ryan-Haight Act, there are some exceptions to the rule that you must examine the patient at least once, and I've listed a couple of them there. The Indian Health Service. If you are a doctor caring for a patient in the Indian Health Service, you can write for controlled substances via telemedicine, even if you've never, ever been in the physical presence of that patient. Now, does this tell us that somehow Indians are less vulnerable to the risks of addiction and to controlled substances than the rest of us? And if so, what are the data for that? What about veterans? The same role applies there. Are veterans not entitled to care that's every bit as careful and thorough and cautious as would be the case for the non-veterans among us? And yet the law allows this to be done for Indians and for veterans. Where is the logic in this reasoning? Public health emergencies. Well, guess what? Our president declared that the opioid problem was a public health emergency. He did that approximately a year ago. Unfortunately, under Ryan-Haight, unless there is agreement between the Secretary of HHS and the Attorney General on which medications are to be affected, then it's as if there were no declaration whatsoever. And there's been no such agreement. Therefore, no such exception applies. Special registration. Congress, in its wisdom, created a mechanism for special registration for telemedicine doctors to write for controlled substances. In the 10 years, roughly, since the Ryan-Haight Act was enacted, nobody, in fact, has actually done that, so that does not exist as of this moment. Next slide, please. This will be very brief. 3 states at least have taken some very interesting approaches, actually more than that, 7 or 8, have taken some very interesting approaches to this problem. In Indiana, there's an exception to the rule about controlled substances for buprenorphine, which is an excellent drug for management of this problem. Trouble is that Indiana is a state. The Ryan-Haight Act is a federal statute. Under the supremacy clause of the Constitution, guess who wins if Uncle Sam fights with the state? Our favorite uncle wins 100% of the time. So nice try, Indiana. Good thought. Florida has a special exception for psychiatric illnesses, of which addiction is one such example. Same problem. Next slide. So what can we do? For one thing, we can activate this special registration rule. There are several statutes currently pending in Congress that would do precisely that. It's a step in the right direction. There have been proposals to waive the originating site restriction, a major problem with telemedicine generally, but for this form of care in particular. Registering addiction centers as clinics with DEA would allow them to create this kind of environment in which they could rate for these substances. SAMHSA could expand on the waivers that are necessary for the writing of buprenorphine. And finally, statewide databases could be made more widely available, not only between states, but also between the states and the federal government, so that those who are writing for these drugs have an opportunity, a better opportunity than they do now, to check to see whether patient X is in fact an abuser or is a doctor shopper or what have you, thereby diminishing the risk. I claim we have a serious problem, we know how to fix it, and it's time to get it done. Thank you.
So we're going to open up for the audience, just any questions? Oh, so many.
With the, in regards to the 2 acts, the Affordable Care Act and the Preventive Health Services Act, with like precision medicine, like pharmacogenetics, especially in the mental health space, with hereditary cancer and carrier disease, more of a preventative, do insurance companies with those acts, do they have to cover these lab or diagnostic tests even though the patient has not met their deductibles?
No.
No?
I mean, neither one. The Health Prevention Services Act actually didn't pass. And the ACA mandates minimum benefits, doesn't suggest specifically what you're saying. Those type of test services, especially preventative services in that nature, generally are not covered unless there's a specific carve-out exception by CMS to cover those type of screening or preventative services. So the PGX, all of that, that's already covered by Medicare. I mean, Medicare is already covering PGX, pharmacogenomics, test services. The reimbursement keeps going down, but those are test services that are covered. They're not covered because of the ACA or the Preventative Health Act, though. So.
What I'm getting at is if they haven't met their deductibles, do they have to meet their deductibles, or is it out of pocket for the patient until they meet those deductibles?
That defers to state law. States regulate insurance policies. They approve, the insurance departments approve those plans and policies. The language generally is that a patient has to meet their deductible before, contract plan language, before the coverage kicks in. And so that's a huge issue when you're dealing with out-of-network providers, and something that I deal with on every single day with providers that are out-of-network because of the narrowing networks, especially in the clinical lab space.
Okay, Brian over there.
Hi, my name is Brian Davey. I'm with the World Bank Group, and we have staff all over the world, virtually by definition working in countries where there's a very substandard healthcare infrastructure. So our standout interest for telehealth is getting access for people in other parts of the world to medical expertise which may be in a different country. So I'm wondering if any of this panel have any experience in addressing the credentialing, medico-legal, jurisdiction type of problems of practicing telehealth across international boundaries.
Yes, I'll say I have. I actually was author of the B&A Bloomberg book. It's a 13-chapter periodical on telehealth. One of the chapters is international telehealth. There are certainly, the same way that the U.S. has licensing and credentialing and registration and the like, so do other countries. So either, one or the other, you're going from you're a U.S. Doctor seeing a patient in Israel, or an Israeli doctor seeing a patient in the U.S. You have to understand the compliance and the regulatory landscape in both countries. I think the biggest issue associated with that and the unknown questions, and I'm sure Joe will touch upon it, is liability, the ability to touch that and what that means and how that'll play out as that continues to expand, as there are experts around the world and that telehealth allows us to connect with. So those issues are still yet to be addressed, but certainly things that we're involved with and counseling clients on.
Thanks. I have not personally had experience in helping with delivery of care to impoverished nations. The only work I've done on international scale involved rather prosperous nations, as it happens. I would suggest, though, that you might want to consider looking, if you're interested in the subject, at a draft convention, a draft treaty that the International Bar Association authored some years ago, intended to create a framework by which real legislators, diplomats could actually create treaties that will permit and facilitate this kind of care across borders. As to Charles's point, the United States is unique in many ways, not the least of which is that we have the most bizarre tort system on the planet, bar none. And fortunately, under current thinking in the United States, care is provided at the location of the patient, not of the provider. So if we have a provider in New York who's caring for somebody in Uganda, to borrow from an earlier example, the care under American law, as generally understood, is considered to take place in Uganda. That makes it hard to bring the case in the United States, which is, from a provider's point of view, very, very good indeed.
So,
Ravi?
this is Ravi Kamepali. I have a question regarding the Nextgen ACOs, and there was a ruling in Federal Registry in December 1st, 2014. There was a waiver on the statutes that does not limit ACOs to bring in rural shortage area where Medicare payments were restricted. So is it still effective, or are people using it or not? I don't see ACOs using them. Am I wrong?
So ACOs are still paid on a fee-for-service basis, and so part of, and there's the shared savings models, and the Nextgen are amping that up and changing that structure. So what the waiver is associated with is the flexibility for the ACOs to provide those services, and it's more or less with managed care as well. But managed care, our Medicare Advantage plans have extreme flexibility to be able to provide telehealth-like services and services that are otherwise not covered under the traditional Medicare Part B fee-for-service structure. So with ACOs, they are under the Nextgen, they are getting a waiver to be able to bill for those services and be reimbursed for those services. As they have demonstrated, there are cost savings associated with that, and so they'll be able to track that as well as part of what the outcomes and what they return to CMS in order to get some part of that shared savings and the risk that they're assuming.
But there's not many people using them, I think.
ACOs are still up in the air on whether or not they're going to survive, honestly. I think that they will, or they'll be an off-breed of some sort. But the goal is with the next generation ACOs is to give them a little bit more flexibility and allow them to, they have some that are very successful. Are they using them? No, not to the extent. I mean, I think we can talk about actually just the utilization of telehealth as a whole. You know, a number of clients that I have, some of them are walking into the employer self-insured, and the employer self-insured plans and the TPAs are saying, well, that's all well and good, but 4 or 8%, I think Ingrid's slide showed 4 or 8% of utilization. Well, I have some clients that can show 40%. And they're in a better position to go in there and negotiate deals, demonstrate outcomes, and demonstrate the savings. So it really is a case-by-case basis. Some ACOs are not, even though they have the ability to.
A question over there.
Thank you. I would like to ask the panel a question about remote patient monitoring. So starting this year, CMS allow physicians to bill for RPM. The question is, a lot of elderly at-risk patients, and then they keep sending the vital sign into doctor's office, but a lot of doctors, they're small practice. They don't have a care team, 24 hours coverage. They're only operating normal business hour. So how can those providers avoid the liability? Should they have a contract with the patient and tell them still go to the ER first, and how to avoid that liability? Thank you.
So I'll just say remote patient monitoring doesn't necessarily suggest that it's for emergency purposes, right? There are a number of reasons why you would have remote patient monitoring. In those instances where, and I don't know how many companies that are tracking those vital signs that would otherwise trigger an alert in an emergency service. I don't know how many companies are out there that are otherwise doing it, but there certainly are liability waivers, and I don't know any practices that are actually assuming the responsibility to monitor those devices should they exist. But they're certainly, if they did take on that role, would certainly have liability to have a 24/7 monitoring, but that's another level, and I'll let the trial attorney talk about.
The good news, two pieces of good news. One, so far, there have been extremely few reported cases asserting liability against telemedicine providers on any theory, remote patient monitoring or anything else. Second, in the United States, in every state, or substantially every state, the test invariably is the custom within the profession. And so, if a reasonably prudent doctor submerged under this tsunami of data does not look at more than one data point in a billion, and that's what his colleagues do down the street and around the state, or whatever the relevant jurisdiction is, in theory, he's complied with the standard of care by definition and has no liability. The bad news is that in all my years of dealing with the opposing side, I have come to develop substantial respect for the intelligence, the tenacity, the creativity, and the avarice of the plaintiff's bar. And the day will come when someone will claim that data point number 4,926 in this tsunami of a billion data points was one that you, doctor, should have been reading at 3 o'clock this morning, and the fact that you weren't is the reason my client has suffered and you owe me $1 million. That day is coming. That's why we have insurance.
Maybe last. Okay.
Yeah, my name is Dr. Fisher. I have a question about the Ryan-Haight Act. So, concerning a strategy in the context of a telepsychiatry clinic that has a physical location, the Ryan-Haight Act has had recent legislation that's pending. It tends to be tied to the opioid crisis bill. The House just passed it a couple days ago. However, I've heard conflicting information that even when passed, it could take up to a year for the DEA to actually issue their special registration. So would it be better to wait for that whole process to carry out, or try to register your clinic as a clinic that can prescribe, as a approved clinic? And I understand that if the state approves you as a clinic, then the DEA will follow along and also say you are a clinic. So I was just wondering about the difficulty of doing that in different states, specifically in Nevada, and whether it's worth pursuing that process financially, time-wise, or whether, really legislation on the other side of it, but the opioid crisis is around the corner.
I'm hesitant to make a statement of Nevada specifically without looking at Nevada law, which I have not done in connection with this particular issue. From what I have read, it seems as though it may be worth trying, in that the probability of success of passage of something that will reform the existing state of the law seems good. There seems to be substantial will in both houses of Congress and on, oddly enough, both parties' parts to try to improve this. But the exact shape it will take is hard to know. And it's not as if filling out the forms and whatnot is a 5-minute proposition. There's a fair amount of effort involved. I suppose it's a question really at the end of the day of risk tolerance. If you're eager to do this and you're willing to accept the risk that it won't fly, go for it. But something I would say to any client, for example, in a state that has enacted legislation to try to circumvent some of the difficulties of Ryan-Haight, what I would say to that client is, well, good luck to you. I'll do all I can to support you, but I wouldn't bet the mortgage that you're going to prevail if someone challenges you on the basis that the state law doesn't trump the federal law. Well, here, in a somewhat analogous fashion, we have the existing law really is the law. You're gambling that it'll change in a fashion that will enable you to justify the expenditure of time and effort necessary to jump through the hoops and become accredited as a clinic in the DEA sense. Hard to know. I would be, again, I think it's risk tolerance of what it comes down to, that and an analysis of Nevada law that I have not attempted.
Have you heard of cases where clinics have been successful in going through the whole process, or is there just a couple and a handful?
I have heard of a couple, yes. Not in Nevada, but that doesn't mean it wouldn't work there.
Right.
The other thing that's kind of interesting is the last time at least the last time I checked this, last time anybody was actually prosecuted under the Ryan-Haight Act was in 2011. Now, does that mean the DEA is asleep at the switch and that you all have carte blanche to do what you want? I very much doubt it. But it may be that the DEA's resources, like that of any other regulatory agency, are limited, and they have to apply them where they think they're most intelligently used and of greatest benefit to their mission. And maybe they don't think this is particularly high on the list, given the other problems the U.S. has with diversion of drugs.
And as an aside, it's amazing how many staffing agencies for doctors violate the Ryan-Haight Act. So many jobs would ask doctors to prescribe, and they seem to say it's okay, and they clearly violate laws. And jobs themselves, hospitals themselves ask, and nobody really seems to enforce it with all these regulations. So
Well, have them contact a good lawyer.
Huh? Yeah. Okay.
Okay, in the interest of time, we're going to wrap it up again. So we talked to a lot of attorneys. These are the best of the industry. So definitely get their cars and hire them. So again, thank you so much. They are the best.